النهارده هنتكلم على السيرجيكال مانجمنت of brachial plexus palsy. We will move from simple to advanced to cover all aspects of the process ونحاول نديلينيت decision making. Theoretically or historically, brachial plexus surgery was considered to be of disappointing results. However, this is a reflection of the complex anatomy, the difficult evaluation and treatment, and the time restriction, which means that after some time بيحصل motor end plate hyalinization، وده بيؤدي إلى إنه even the nerve, if it grows, it does not reach the target organ. Type. We limited donors because I can sacrifice very few nerves to do that. However, in the last 3 decades, there were significant developments in the management of brachial plexus surgery. والنهارده بقدر اقول بمنتهى الثقه العيان بتاعي ان انا in 95+% of conditions, I'll be able to bring you some function, we're able to improve your function of your upper limb after surgery. بس طبعا gratifying results دي محتاجة communication عالي ما بين الجراح والمريض himself. الchanges mainly في treatment strategy، في timing strategy، في investigations وفي new frontiers of treatment options. بس خلينا نبتدي من basics عشان نغطي النور. This is the brachial plexus. It's mainly divided from roots to trunks to divisions to cords. It has a very complex anatomy that should be studied in detail by anybody who's going to embark on brachial plexus surgery. It's been a very old disease, and in literature, since it started to be documented في منتصف القرن ال19 been authored by people, a lot of people there. Leifert classification approach الباثولوجي او بتابروتش التكنيك بتاع الميكانيزم اوف انجري فهي بتقسم الانجريز into open injuries, closed traction injuries, radiation injuries, and obstetric injuries. عشان الاوبن injuries والradiation injuries are of this very specific etiology وبالتالي very different treatment، فانا هبتدي بيها بعد كده مش هنذكرها وهنكمل في المانجمنت of closed injuries. Closed injuries can be adult brachial plexus palsy or can be an obstetric brachial plexus palsy. طيب, what about penetrating injuries? Open injuries might be a sharp injury, knife, glass، ودي بتعمل one of two things. يا اما العصب يتقطع complete neurokinesis, or it was not touched by the knife and it is intact. So the type of injury is either neurokinesis or intact. Surgical repair must be done as soon as possible if there's a nerve defect. There's nothing called neuropraxia or axonokinesis in sharp penetrating injuries. What about gunshot injuries? Gunshot injuries are quite different. They are rarely complete palsies. High velocity injuries بيبقى معاها direct tissue destruction, thermal injury, و severe stretch in the 3 zones. Do you see my pointer? Probably not. 3 zones of injury. Direct tissue destruction, حواليها zone of thermal injury, حواليها zone of severe stretch. There's a mix usually بالpenetrating injury of neurokinesis, axonokinesis, and neuropraxia. في حين ان shotgun injuries اللي هي الخرطوش are usually very benign injuries. The upper trunk, lateral trunk, posterior trunk have best surgical outcome because they are shorter. The target organ is closer. While conservative treatment is advocated if there is improvement, the indication of surgery should be no recovery, so clinically or by EMG, at 3 months duration. Why do you wait 3 months for this? Because of the mixed nature of the injury. We will not be able intraoperatively to distinguish between the different types of injury except when fibrosis happen. الفايبروزس اللي بيحصل في النيرف لما يبقى injured هو اللي بيبوينت اوت المكان والليفل والdegree of nerve disruption in anything but neurotomesis. يعني الاكزونوتوميسيس اللي هي النيرف is in continuity is very difficult to pick up zone of injury فين بالظبط. لو ما ساندرلاند تايب 2 3 and 4 ويا ريت اللي ما شافش محاضرتي الاولانيه يشوفها لان it's very important background. دول ما بنقدرش نفرق بينهم intraoperatively الا بعد ما يمر 3 اشهر من الانجري. What about radiation injuries? They're becoming increasingly frequent مع ال success of radiotherapy for treating بالذات breast cancer. They are related to the dose, the frequency, and the number of sessions, as well as the extent of the field. Axonal effect might be from just swelling and edema to even complete degeneration of the Schwann cells and the neurons with progressive scarring and eventual neural element disappearance. It's difficult to distinguish recurrence from infiltrating breast cancer from plexusopathy of radiation, except انه plexusopathy of radiation تبقى diffuse involving the full plexus, while the recurrence of the tumor usually starts from below up, affecting first the T1 root, which would probably give you a Horner syndrome, one of the very first signs of an infiltrative breast cancer. There's no consensus of treatment. حاجات كتيرة جربت simple neurolysis with transplantation of soft tissue من ضمنها الأومنتم عشان يحسنوا blood flow gliding بتاع النيرفز. It's a very, very sad injury. It should be prevented. Closed injuries are usually through traction. والtraction ده depends على the position of the neck. If my neck is straight and there is traction on my arm, straight parallel to the traction is in parallel to the neck, the lower trunk structure first. While if my neck is drifted away, the upper trunks seem to rupture first. وده نفس الميكانيزم في obstetric brachial plexus palsy. There are 5 levels of injury. يا اما avulsion of the roots, spinal nerve root avulsions. دول بيدوا preganglionic lesions واحنا هنسترس قوي ايه الفرق بين preganglionic و postganglionic lesion. يا اما the spinal nerve itself will be injured, the trunk or the cord or the peripheral nerve. يعني I know you can see my pointer. إذا الانجري هنا دي اسمها avulsion of the root، هنا تبقى avulsion of the ventral root، وما شفناش حاجات فيها avulsion of one root والتاني intact. يا اما في هنا rupture يبقى ده spinal nerve injury، يا اما distal هنا يبقى اسمه peripheral cord، يبقى cord trunk cord or division or peripheral nerve injury. طيب فالافولجنز تمتاز انها افولجن من السباين ويبقى من الكورد وبيبقى فيها الروتس are with the nerve والposterior root dorsal root ganglia is in continuity with the nerve. Outside is a postganglionic injury. It might be a stretch, a form of axonotomesis or a neurotomesis if ruptured. Liefert, in his classification, he stresses a lot to pick up the difference between a nerve root avulsion and a preganglionic lesion or a postganglionic lesion. ليه؟ Then prognosis for avulsion is very bad and it should be managed surgically faster than your postganglionic. لأن preganglionic lesions, the avulsion is so proximal and مفيش nerve is inside the meninges. So inside the meninges there is currently glial inhibition وبالتالي مفيش nerve regeneration. So an avulsed root will never regenerate on its own. طيب كويس جدا. ايه الفرق بين ده كلينيكلي؟ ان الدورسال روت جانجليا دي في الافولجن معانا فلما بنعمل sensory nerve action potential في الحته اللي العيان مش حاسس بيها، هو بتجيلنا a normal response، لان الدورسال روت جانجليا فيها دورسال روت هورن سيل، فهتبقى ال sensory nerve action potential is normal. تمام؟ مفيش proximal stump، مفيش nerve degeneration، فمفيش نيوروما، فمفيش tunnel sign. لو عملت سي تي مايلوجراف او ام ار اي داي او حاجه من الحاجات الحديثه، هنشوف سودومينينجوسيل. Horner syndrome is a sign of T1 avulsion, denervation of the posterior primary rami, phrenic nerve, rhomboids with serratus anterior, دول sign of root avulsion. While in postganglionic lesions, the dorsal root ganglia is intact, the roots are intact, with proximal stump neuroma بتتكون في بوزيتيف تانل، ما بيبقاش في الام ار اي في سودومينينجوسيل. This is very important بالذات في البيدياتريك brachial plexus. This is a Horner syndrome. Horner syndrome is T1 root injury, avulsion, and it's ptosis, meiosis, and anhidrosis, and hypothalamus. طيب the denervation of the posterior rami is associated with an elevation of the diaphragm. Diaphragm هنا الكوبيولار diaphragm is so high. This is why because the diaphragm is paralyzed on the side of the injury. ده له implications على التخدير. مفيش عيان pediatric brachial plexus palsy ينام من غير chest x-ray عشان نأسس level of copular diaphragm. وفي نفس الوقت كمان ده بيقول لنا ده preganglionic lesion، بس in this preganglionic lesion ما اقدرش at an initial stage ان انا اخد intercostals as a graft or as donor. I'm sorry, because the lung on the affected side is only irrigated by the function of the intercostals. Dorsoscapular nerve بيدي rhomboids، والrhomboids لما تبقى paralyzed يبقى في slight lateral tilt and rotation. ما اعرفش الصوره مش مقنعه قوي برضو. long thoracic nerve يبقى مع winging of the scapula في الوضع بتاعت البوش فوردز زي الضغط على الحيطه.
دكتور اشرف بيه،
اي فندم،
ممكن بس نعلي الصوت شويه؟
طيب
او حضرتك لو تقدر تعلي التون او كده.
حاضر. اسمحوا لي احاول ان انا اعمل حاجه صغيره. في السودومينجوسيل بتبقى موجوده في الام ار اي وفي والسي تي مايلوجرافي علشان البريجانجلونيك lesion is an avulsion of the root، ففي injury inside the meninges. اوكي؟ طيب زي ما قلنا السنسوري neuron action potential is normal even in a sensate area. الالنر نيرف الميديان نيرف ديستريبيوشن بالعين مش حاسس، بس الاي ام جي بيطلع normal sensory neural action potential. اوكي؟ طيب ده على عكس البوست جانجليونيك. بوست جانجليونيك ليجن السنسوري نيورال اكشن بوتنشال شوز ا ليجن، في بروكسيمال نيوروما جروث وفي ستامب، ففي نيوروما وتينل ساين بوزيتيف اند روتس ار انتاكت، ما فيش سودو مينجوسيل في الام ار اي ولا في الزوجرافي. اوكي؟ طيب Obstetric brachial plexus palsy بتتقسم الى 3 انواع for theoretical purposes، وان كنا بعد كده هنحسبهم 4 انواع. النوع الاولاني هو الاربس بولسي المشهوره بالاسم ده، لكن هي C5-6 involvement and it is the most common lesion. Actually 53% من الاصابات C5-6 or C5-6-7، والبروجنوز بتاع C5-6-7 is close to C5-C6. التوتال brachial plexus palsy نسبتها 45%. ال 2% remaining zonal as clumpix palsy, and it's an isolated C8 and T1 palsy. But I have to say here that a lot of the surgeons do not believe that a pure C8 T1 injury exists, they believe that this is a later presentation of a total brachial plexus palsy that has recovered the upper trunks. والconsensus دلوقتي ان maybe isolated C81 is a non-recovering form of the total brachial plexus للlower trunks. طيب the most commonly used في ال differentiation of brachial plexus palsy is the Gilbert classification, in which he says there's group 1 and group 2. Group 1 is a C5-6 damage. دول بيبقوا عندهم loss of shoulder movement completely and elbow flexion. ان ده C5-6 pure. where you can expect spontaneous recovery in 80% of cases. While a C5-6-7 lesion هيبقى معاها weak wrist extension, where spontaneous recovery would recover in 60% of patients. طيب أنا هنا لازم أنوه عن حاجة في منتهى الخطورة. A lot of the physiotherapists بالذات بيقولوا إنه most of these patients recover well. Most of obstetric brachial plexus palsy, they recover well, and we should not operate. This is really true لما تبصوا على الأرقام. تبصوا على الأرقام إن 53% بيتحسنوا ما بين 80 ل 60%، يعني نقول 70%. فالمعظم بيتحسن كويس. However, if you are from the unlucky 20% or 40% that did not recover, you have lost your chance of recovering a good limb. Especially in the type 1, group 1, group 2 دول, they have an excellent result. يعني أنا عايز أقول لكم إنه منتخب مصر للباسكت الكرنت تشكيل بتاعه في بنت أنا عملت لها بنفسي شورال nerve graft C5-6 rupture at the age of 4.5 months. فوصلت الريكفري انها تلعب منتخب مصر في الباسكت بول. اوكي. طيب look at this posture. The posture is very characteristic. The shoulder is adducted, elbow is extended, and the wrist is flexed. ده في C5, C6, C7. Okay. معظمهم بيattain normal function, and we should follow them up closely to pick up اللي مش بيريكفر. وهنتكلم مع بعض يعني ايه pick up الناس اللي مش بيريكفر. إذا كانش في recovery, we'll have to interfere by nerve grafting, release the contractures, and or tendon transfer. طيب الobstetric brachial plexus palsy group 3 is complete paralysis. ودول للأسف spontaneous recovery is only 30%, while grade group 4 is complete brachial plexus palsy with the Horner syndrome. ده معناه انها preganglionic. Full spontaneous recovery will never happen. You have to interfere with those patients. خلي بالكم انه there can be a mix. There usually is a mix, or more commonly there's a mix between pre and postganglionic complete brachial plexus palsies. طيب الimaging studies has really developed, واخيرا بقى عندنا في مصر سنه 2000 اخر 2019 او نص 2019 MRI neurography بقت تقدر تدينا valuable tool. بس MRI myelography برضو is quite useful to detect meningoceles and can detect can المستقبل هتقدر differentiate between avulsions and ruptures. طيب ايه اساس علاج البريكال بلكسس جروب 1 و2 و3 اللي هم معهمش هورنر سيندروم اللي هم مش بريغانجليونيك؟ اساس العلاج is conservative treatment, prevention of contracture, and follow-up neurological progression. طيب يعني ايه الكلام ده؟ يعني we prevent contracture by الام بتتعلم teach the mother for range of motion, for shoulder exercises, starting from the age of 3 to 4 weeks. We usually wait to that age because sometimes there's a fractured clavicle, is an AC joint injury, there's some injuries in the local bony or soft tissue injuries. So we like to postpone الabduction والexternal rotation exercises وهم دول exercises أساسية till the age of 3 or 4 months. We follow the patient every month to pick up a recovery, and child must achieve the milestones. What does milestones mean? Milestones means من عهد الرومان لما كانوا بيحتاجوا when the Roman Empire was leading the world, one of their things is that they used to open the roads between their countries, and they could put big pieces of stone along the road saying you are 20 kilometers away from Alexandria, you are 40 kilometers away from Alexandria, you are انت 200 كيلو من اسكندريه. What I tell to the family of the patient when they come, now we are waiting for the nerve to regenerate. The nerve to regenerate must prove that it is growing, which means when we ride the car together and it says 200 kilometers to Alexandria and half an hour passes and we are still not 190 kilometers from Alexandria, that means we're not achieving the expected milestones. But if it's saying 150 kilometers Alexandria, then we're at good speed, we're recovering well. The recovery of obstetric brachial plexus palsy has been very well studied. There are well-recorded milestones of recovery. If the patient is not progressively recovering with return of movement, return of functionality, progressing Tinel sign, or a progressing EMG findings, then the child is not achieving the milestones, and this is an indication of surgery. The timing of surgery has really changed to a much earlier approach. Usually احنا كنا بنعمل العمليه دي بعد 3 شهور، بعد 6 شهور من 6 شهور من الاصابه علشان this is what we've been taught. But the current teaching over the last 2 or 3 decades, we say that we immediately interfere إذا كان في vascular injury وإذا كان في open injury. And by the way, إذا كان في vascular injury, this is one of the worst types of recovery, especially in gunshot injuries. While if we detect root avulsion, we go as early as 6 weeks inside. If it's a group 4 by Gilbert, we go in at 6 weeks. But the routine بتاعنا دلوقتي is usually at 3 months. We try to avoid the 6 months because 6 months is late. We try to be closer to the 3 months mark to interfere. After 1 year, it's very controversial. We have a paper saying that we get recovery even much later than that. But the standard and recovery and prognosis is much worse, and you should think of reconstructive options if they're available. So, emergency penetrating injuries, 6 weeks up to 12 weeks if there's signs of poor prognosis, which is a flail limb with severe pain, preganglionic injuries زي ما قلنا pseudomeningeal, positive Horner sign, diaphragmatic palsy, high velocity missile injuries is also an indication for earlier exploration. Waiting for the routine اللي هو 3 months will allow the demarcation of the area of injury and differentiate which injured nerve is affected more. طيب خلاص, we decided to go to surgery. ايه surgical options? Classically كان عندنا الأول 3 اختيارات هم دول اللي احنا الستاندرد بتاعنا. هي neurolysis, which is always very gray and a very not easy decision to make. When you do neurolysis, you think you didn't do anything useful. It might be useful, might not be useful. لأن طبعا when you find a neuroma in continuity, you should and it's conducting, that's the only thing you do neurolysis in. But if you find a neuroma in continuity and it's not conducting to electrical stimulation or conducting لسوماتيسنسوري evoked potential لو كان available، يبقى ده معناه انها non-conducting neuroma and it should be excised and repaired. Nerve repair is very rare to do, which is direct repair, but usually we need to do a nerve graft. والnerve grafting حصل فيه تطورات كتيرة هنتكلم فيها مع بعض. However, the last 2 decades في كذا قفزة، a lot of jumps in the prognosis in the development of nerve surgery in brachial plexus palsy. We have nerve transfers, neutralization from either nerves, intact nerves inside the plexus itself, or from extra plexus sources. ده هو حقيقي اللي فرق جدا خلال العقدين اللي فاتوا 20 سنة اللي فاتوا. And the other is end-to-side and side-to-side nerve grafting and free muscle transfer. في changes كتيرة في التندر transfer وفي joint fusions. البيونكس فرق كتيرة جدا جدا معانا والfunctioning prosthesis، ولكن دول انا مش هقدر اغطي لا التندر transfer joint fusions ولا البيونكس، especially ان هو في الميدل ايست they have a very limited role, they're too expensive to انا اسف بالنسبه للبيونكس at least والfunctional prosthesis to use. طيب فاحنا هنديكيت الحته الجايه للنيو فرونتيرز، النيرف ديستال نيرف ترانسفير نيوتراليزيشن هي اهم حاجه، الاند تو سايد وسايد تو سايد جرافتنج، الفايبرين جلو ونيو نيرف جرافتس نيو نيرف تيشو، التوتال بريكيال بلكسس بولسي حصل فيها تشينجز احب برضو انوه لكم عنها، والتندن ترانسفيرز مش ناويين نغطي. التارجت بتاعنا ان احنا بنعمل نفتح transverse incision parallel to the middle third of the clavicle. أنا أشرف بخليه parallel to the middle half of the clavicle. And if we need to go supraclavicular, we go parallel to the posterior border of the sternocleidomastoid to the mastoid process, the upper 2/3 of that. Or if you need to go below that, we do go a deltopectoral approach if you need to infraplexus based على الcoracoid process. And then we can have a good exposure supraclavicular or a good exposure infraclavicular as well. Sometimes we need to extend a little bit more distal to get intercostal زي دول ال 5 intercostal nerves when we use them as a donor nerve extra plexus causes. الفايبرين glue is a jump بيزود الefficiency والtiming it's been proved to be as effective as sutures, maybe a little bit more effective إنه less fibrosis. However, the crucial thing is proper apposition of the nerve fascicles. This is very crucial in the nerves يبقوا كده, okay, because they might heal like this, بس ما لوش يبقوا كده إذا بقوا كده عمرهم ما هيلتئموا, okay. They have to be well opposed. Get the best opposition you can get with sutures, with fibrin glue, but get opposition. I personally use few sutures to hold and then I glue that together. Okay? Type. What about nerve transfers? They are the Renaissance. Renaissance يعني عصر النهضة in brachial plexus surgery. Because they supply a target recipient closer to it, فبيمينتين ويسبيد الريكفري وبيمنع دي hyalinization of the motor end plate, فبيرزيرف المسل structure and function. والتكنيك ان احنا بنجت a sacrificable nerve we can sacrifice and we transfer that end to the paralyzed muscle in lower motor neuron lesion, and we do that much closer to where the site of injury is. وهنشوف examples كتيرة لهذا. طيب النيرف اللي هناخده الدونر should be expandable, should be of the same type, sensory or motor or sensory motor, should have an adequate number of fascicles, and should be synergistic. يعني احنا بنقول السينرجي wrist extension مع finger flexors. So I can use a finger flexor to support my wrist extensors, or wrist flexion finger extension. فدول are synergistic، والحاجات السينرجستيك معروفه لبعضها. The major advantage of tendon transfer ان احنا we maintain the normal musculotendinous dynamics of the original structure. طيب principles of nerve transfer انها تدي better functional recovery than tendon transfer should be. بس we could not do a nerve transfer. We could do it after 6 months of the injury, very close, but we cannot do it after 1 year of the injury, because by then probably الهايلايزيشن اللي حصل في الموتور اند بليت. طيب ايه الدونرز؟ الاكسترا بلكسس دونرز، الدونرز جايه بره اشهرهم السباينال اكسسوري والانتركوستالز. الانتركوستالز كومن جدا نستخدمهم للبايسبس، كومن جدا نستخدمهم لل median nerve, especially in فيهم sensory component as well, while spinal accessory is very common to take to the suprascapular nerve or maybe biceps, maybe other nerves, very versatile بصراحة. Contractile C7 is a huge thing we're going to talk about by the end of the lecture. The phrenic nerve, people are moving away from thinking the phrenic nerve for various reasons. While interplexus donors, معظم أعصاب الجسم were taken as donors, redundant branches, extra branches. We're depending on ان في cross innervation، وان هو وانه في more than one donor physically بتروح للموتور للrecipient، وبالتالي it is almost medial pectoral was used, branches from medial nerve to medial teres, flexor brachialis or superficialis. Branches of the nerve to FCUs commonly used. The pterygosus nerve بعد ما يعدي يدي ال FPL وال radial half of FDP بناخده ونستخدمه هو رايح للquadratus. والbranches of radial nerve to the medial head of the triceps or lateral head of the triceps، أو ساعات حتى even the long head of the triceps can be used. طيب. What about elbow flexion? Elbow flexion is one of the most successful في nerve transfer. ممكن زي ما قلنا intercostals, medial pectoral, phrenic, thoracodorsal, spinal accessory. لكن دلوقتي the most common we use is what's known as the overland transfer, which is branches from the media, from the ulnar fascicle to FCU to the biceps, or most commonly now used is called the double fascicular transfer, which we do an overland, ulnar to biceps, or we do median FCR or posterior teres to the brachialis. So we have both of the brachialis and the biceps functioning. The nerve transfer success rate again بتاعها في البايسبس is close to 90% plus. طيب what about shoulder abduction؟ أحسن حاجة إن احنا نعمل ترانسفير للsuprascapular nerve والaxillary nerve في نفس الوقت. النيوتراليزيشن of the suprascapular nerve is more reliable and more important than the axillary nerve، لأن الsuprascapular nerve بيدي كمان external rotation مع الabduction. طيب the most common is spinal accessory، بناخده نحطه في suprascapular nerve. You could see from my pointer, this is your suprascapular nerve and this is your spinal accessory nerve. انتوا شايفين المسافة قريبة قوي ازاي بناخده نوصله end to end في هذه المسافة. It's really close and very nice, very relaxed transfer. This is conventionally بيتعمل من anterior approach، من الابروتش اللي شفناه زي ما كنا بنعمل brachial plexus. لكن لما يجي عيان مش هنexplore البلكسس we can do it from a posterior approach. ولقينا الريزلتس بتاع posterior approach احسن. وبعد كده we did عندنا في القصرينية research على what we call an extended anterior approach، لان احنا بنقول ان الفرق ما بين الانتيريور ترانسفير والبوستيريور ترانسفير هو البوستيريور ترانسفير بيفك ما يسمى الترانسفيرس سوبراسكابولار ليجامنت. وعملنا الدراسه دي على 42 patients. We released the suprascapular nerve ligament from anterior and we did our transfer, and this is your suprascapular nerve and this is the suprascapular ligament, and these are the suprascapular vessels. We release this مع nerve transfer from anterior. This is the picture, and we proved statistically significant better outcome when we release the suprascapular transverse scapular ligament over a suprascapular nerve transfer, spine accessory to suprascapular nerve transfer. طيب, what about lower trunk injuries اللي هم CAT1؟ ما هماش بنفس النجاح، ولكن the most common transfers are from the musculocutaneous nerve to the posterior fascicular group of the median nerve, which mainly anterior interosseous to achieve some finger flexion. And the motor branch of brachialis has been used on the anterior interosseous nerve as well to help in finger index and ring maybe flexion as well as thumb flexion. طيب, end to side والside to side nerve grafting utilization is really depends على انه لما بوصل العصب ببعضه في a lot of chemotactic factors, neurotrophic factors that help the nerve to regrow. We call this axonal sprouting. Axonal sprouting is the future بالنسبة لنا كلنا. وفي الآخر وأنا بختم هقول why is it the future. فالأxonal sprouting في الend to side والside to side has been well proved and has improved a lot of results. ده بيوفر donor، بيوفر sacrifice of a nerve، وبيساعد في recovery of a partial nerve injury. ما بتقطعش recipient if there is coming. يعني ده by the way is an ulnar nerve that I've repaired proximally as well. بس أنا واخد النيرف supinator quadratus زرعه في end to side هنا علشان this will by axonal sprouting give some nerve fibers to the ulnar nerves supplied lumbricals and thoraci, and this would prevent them from atrophy and maintain their function. 2003 I presented this presentation of hand surgery وسوزان اللي كان نشرتها بعد كده في 2005 وسميتها baby sitting, which means you put a nerve end to side on a strong nerve like this وده بيمينتين ويمنع nerve degeneration. This is our study for supercharging or babysitting the ulnar nerve في elbow level lesions, and this is my ulnar anterior interosseous nerve بعد imperative quadratus being passed multiple passes. Where we use the same technique in 2005. We published end to side to side for brachial plexus neurography, and we did that in another publication in 2006. These are the techniques of end to side and side to side we used in these papers, and these are case examples in which we find a partially conducting neuroma, and we do a jump cable or a nerve side to side. We do a side to side to supply the rest of the partially regenerating nerve, and we have good elbow and wrist function. Right. What about nerve grafting? Nerve grafting is really the mainstay for overcoming defects. هو الجولد ستاندرد، هو اللي بنقارن بيه، بس في مشكلة كبيرة جدا إنه the number of nerves you can take is limited in a person. Most commonly بناخد الشورال, less commonly بناخد medial cutaneous nerve of the forearm, but we can take other nerves. بس كل nerve بناخده فيه donor site morbidity. فالموضوع ده خلى العالم كله تبحث في alternatives nerve grafts. في natural alternative nerve grafts mainly الفين كوندويز. يعني ايه الفين كوندويز؟ وضربوا فاشة كل حاجة. ناخد فين ونزرع جواه النيرف اندنجز بتاعتنا. لما نعمل الفين كوندويز دي ده بيدي some regeneration. ممكن ناخد allograft. الالوجرافت ده بتبقى processed بحيث ان كل البروتينز تلوز الانتيجينيستي بتاعتها، وده is a very common thing في اوروبا وفي امريكا، في اوروبا المتقدمه زي ما بيقولوا, but it's not available in our Middle East. Synthetic grafts have also been tried and with some success, بس كل الحاجات دي بتaim at directing axonal sprouting from the proximal to the distal. They have been proved to work, especially in gaps less than 3 centimeters. But more than 3 centimeters, there are still very, very challenging, and still need to do a natural nerve transfer, an auto nerve graft. More success in less than 3 centimeter defects was used in brachial plexus palsy, but not used in obstetric brachial plexus palsy. طيب, what about the developments in total brachial plexus palsy? الdevelopments in total brachial plexus palsy in adults بالذات are devastating, and there was very little we can do about it. في عندنا قفزتين في الحته دي مهمين جدا نتكلم فيهم. عندنا الcontralateral C7 transfer, الcord replantation, اوكي, والفري functioning muscle transfer. الcontralateral C7 ابتدت اتوصفت من نص السبعينات بفاسكولارايزد ulnar nerve من تايلر اند هام دلوقتي، وبعد كده اتوصفت ب شورو نيرف جرافت، اتوصفت بكذا تايب اوف جرافت. لكن however now it's there is a renaissance in which كان الروت بتاع الترانسفير دايما subcutaneous. دلوقتي we're going ما يسمى pre-spinal روت. وخليني اشرح لكم الحته دي. كان دايما بناخد الكونترال سي 7 على نيرف جرافت طويله تحت الجلد in front of the sternum, and it goes into the arm, usually taken free sural or vascularized, but now we're more using a pre-spinal route. This is the subcutaneous transfer. This is the standard pre-spinal retroesophageal route. Now we're even using a more advanced, more closer lesion اللي هي really pre-spinal route. We cut through the prevertebral muscles, and this is a pre-spinal route described by Zoom 2008. This is the most commonly used. والZoo approach ده بصراحة خلينا نقدر نعمل end-to-end graft. يعني بتوصل C7 crosses and reaches to go to end-to-end. Yes, end-to-end. فيها كام trick. Sometimes we need to shorten the humerus 4 centimeters to achieve end-to-end nerve repair. Is it worth it? Yes. We know that every nerve anastomosis in the best hands, 70% of the donor nerves pass to the recipient nerve. So if you have a graft, we lose in the first side 30%, and in the next anastomosis we lose 21%, which is 30% of the remaining 70%. So we have a 50% better regeneration if we do an end-to-end nerve repair without a graft. وده ممكن نعمله، ممكن نساعده بشوية humeral shortening, and this is well described. So this is one of the jumps in end-to-side, in cross C7 nerve transfer. We open both brachial plexus, we cut the C7 root, and we flip it. My Nelton tube here is actually passing in the prevertebral root, and then we pass it through, and it reaches the anastomosis site on the other side. Okay. Type. What about replantation in brachial plexus? The earliest forms of replantation was reported more than a century ago, 1911. However, it was not successful, and we even did a good study on that with some good results, but it was a very big surgery that was published in 2009 in the Journal of Brachial Plexus and Peripheral Nerve Surgery. This entails a huge anterior and posterior approach, a laminectomy, and then we pass the nerves and the nerve grafts through the spinal cord. We noted some nerve regeneration, and we think that this is because, now we think that this was because our nerve graft passed through the spinal cord. But however, we know why does the CNS, the central nervous system, not regenerate? Because the glial tissue has nerve inhibition factors, nerve growth inhibition factors. And now the future would be nerve growth factors to be injected locally at the site of the sources, intraspinal, and it is being clinically and currently used and for what they call off-label uses. And I think in the near future we will be able to be doing much more cord reimplantation for nerve avulsions. Free muscle transfer is taking a muscle, this nerve and blood vessel, and anastomosing it to maybe intercostals, to an extra plexus donor, and using it to regain wrist, finger flexion, elbow flexion. It is a common procedure now done. However, my impression is that the patient satisfaction is not that high as initially reported, although we're becoming technically more skillful in doing it and making it do more functions. Tendon and joint transfer and joint fusions is an option for reconstruction when you can't do that. Bionics, a lot of advances in bionics has been done, especially with probes being distributed in different parts of the body to pick up which movements you want to move. In conclusion, early is crucial. Hopefully, thinking can be harmful. Waiting for just something to recover, which is not following the milestones of recovery, is damaging your son. للأسف الشديد لا يزال الناس بتنصح في conservative treatment brachial plexus palsy. أنا الأسبوع اللي فات ده تقريبا طردت عيانة، طفل عنده 3 سنين، من 3 سنين. We had a lot of we could have done to this guy, but now very little we can do. There's a bigger and better role with nerve surgery, with reliably better outcome, and in reliability of a better outcome. We used to say in the priorities of reconstruction goes to elbow flexion, then shoulder stability, then goes wrist and hand, wrist movement and hand sensibility, and at last intrinsic and flexion. Now this order has changed. We always run to recover hand function, because the whole value of the upper limb is to position the hand in space, because the hand is our effector organ. بشكركم جدا على حسن استماعكم. Thank you very much, and I hope this was useful and to the point. Thank you.
What about the role of nerve conduction study and EMG and the first time to do and follow up?
بشكر ايفون جدا جدا على السؤال ده، مكتوب اسمه كده، انا اسف. What's the role of EMG? هو I beg you watch my first lecture on nerve injuries مع دكتور محمد هاني ومدينة نصر. Because I did that very covered. However, هو الدكتور لواء from العراق هو الايفون. شكرا دكتور لواء. We say that the first 3 to 4 weeks after injury, the EMG will never pick up any changes. So don't do it before 3 to 4 weeks. However, at 3 to 4 weeks, you will be able to pick EMG changes. You repeat that after another 6 weeks at least, to pick up 6 weeks or at 3 months, 2 months بعد اللي عملتها الأولانية. You pick up the first signs of recovery. Neuropraxia and axonotmesis, benign types, axonotmesis اللي هي 2 and 3 will probably show some significant recovery, and you will be able to pick up this recovery. However, if there's no signs of EMG recovery in your 3 months follow-up, that means that there's no motor unit action potentials, no MUPs. That means it's not recovering. Okay? And if there are scanty MUPs and polyphasic MUPs, you can wait. بتعيد تاني لسم العصب بعد شهر أو 2 أو 3. But at 6 months, if you don't have proper MUPs, motor unit potentials, in your recovering muscle, it will never recover. And this is the time to interfere. دكتور شهاب هزاع من اليمن، قلبنا معاك وشكرا لمجاملتك الجميله. شكرا جزيلا. انا مستني اسئله كمان، شات بوكس كله شكرانيات. اشكركم جميعا.
اعتقد يعني متهيألي النهارده المحاضره مع المحاضرات الجميله بتاعت المره اللي فاتت يعني كانت اكثر من رائعه، وحضرتك وصلت المعلومه الحمد لله. يعني واضح ان يعني الموضوع اتهضم كويس والناس كلها يعني
هو الموضوع صعب،
تشكر.
وانا تحت امركم في اي اسئله سواء على الصفحه او على دكتور محمد هاني. دكتور محمد هاني هعطي لكم اليوتيوب channel link. Please, if you have any questions, I'm more than happy to answer. أنا باخد البريكال plexus palsy والnerve injury in general very personal because I think we can do a lot of good للعيانين دول، وإن هم حقيقي ناس عندها nerve damage are really 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 unhappy people. Histamine test just histological. لا, it's useful برضو. I don't use it, but it's useful. Some people use it. One of the tests برضو الهستامين تيست والرينكل ساين. رينكل ساين انك تحط ايدك في ميه دافيه، فده يخلي الصوابع تكرمش. الصوابع الكرمش او العين يبقى هستامين تيست بوزيتيف، ده معناه ان في نيرف سنسيشن. ده very important عشان to pick up المالينجرر من المالينجرر والسايكوتيك. انا اسف، المالينجرر والمش سايكوتيك والسايكولوجيكال اليمنتس من الاورجانيك. اوكي، فده دور الهستامين تيست والرينكل ساين. دكتور احمد الزعبي من الاردن وحاليا في ايطاليا بيسالنا ايه الفانكشن you lose on the good side of a contractile C7. Usually nothing. Some numbness might be there on the radial border of the forearm for some time. عندي عيان جاله شويه weakness of this dorsiflexion, usually recovered very well. Ortho everything is asking when do I do a muscle transfer. شوف سعادة الباشا, you aim at nerve reconstruction at the first 3 to 6 months. من 3 to 9 months you aim at nerve transfer. بعد سنة you have only tendon transfer. very rare ان nerve transfer تنجح. دكتور لواء في العراق تاني بيسأل are the role of limb position abduction exonotation while waiting for recovery. دكتور حازم الحسن من السودان بيشكر شكرا جزيلا. What I'm saying is ان في الobstetric brachial plexus palsy الinternal rotators بيبقوا stronger than the external rotators. The external rotators are lost مع suprascapular nerve C5. فالارم بيبقى inherently in internal rotation، فده بيعمل glenoid version، بيعمل deformities في الهيد، وبيعمل ممكن subluxation ممكن dislocation. we have to train the mother to bring the arm into external rotation in ADD adduction, and external rotation in abduction, statue of liberty position. Okay, but external rotation has to be done by the mother every time she breastfeeds her child. تمام. لكن in adults مش هيحصل bony deformities, but range of motion is very important to be maintained.
تمام يا بيه. اعتقد يعني احنا خلصنا سيشن الاسئله ولا ايه؟ مش عارف، انا حاسس ان
humeral ايمن بيسال عن humeral rotational osteotomy. humeral rotational osteotomy has a role في الموقف الاتي. احنا قلنا الobstetric brachial plexus palsy بيحصل فيهم deformity في الهيد وفي الجلينويد. If I have a deformity في الهيد والجلينويد والarm is in too much internal rotation, I cannot do a tendon transfer. I do a humeral osteotomy, but if the head is spherical and the glenoid is in a good position, I do a tendon transfer. The standard tendon transfer is latissimus dorsi to supraspinatus and teres major to infraspinatus. في ريسيرش طالع من القصر العيني بيقول ان كفايه قوي latissimus dorsi to supraspinatus and I tend to agree with this, although sometimes I feel I need both limb transfers together. فالروتيشن osteotomy هو في وجود internal rotation deformity في neglected Erb's palsy معاها glenoid and humeral head deformities.
تمام يا فندم، ربنا
تمام.
يزيدك علم ويرفع من قدرك يعني،